Chapter 24 covers obligate intracellular organisms that are either extremely difficult to culture or are non-culturable. This includes Chlamydia, Rickettsia, and similar organisms. The very small size and obligate intracellular parasitism are major characteristics that differentiate the organisms of the genre Chlamydia, Chlamydiophila, Rickettsia, Aurentia, Anaplasma, and Ehrlichia from other bacterial species. Since these organisms are difficult to culture or non-culturable, molecular biology assays are used to detect the more commonly seen pathogens. Table 24.1 in the text shows comparative properties of the various microorganisms, comparing typical bacteria to Chlamydia, Rickettsia, and then mycoplasmas and viruses. So note that Chlamydia and Rickettsia, along with viruses, require a living medium for growth. As you can see in the characteristic of growth on non-living media, Chlamydia, Rickettsia, and viruses are negative. So these organisms will grow in cell culture opposed to plain agar medium. They're also obligate intracellular parasites, as we mentioned, so they need living cells to survive, hence they need cell culture to be grown. The family Chlamydiaceae now consists of two genera, Chlamydia, which includes Chlamydia trachomatis, and Chlamydiophila, that includes Chlamydiophila pneumonia, Pistachiae, and Picorum. There are other species of chlamydia that exist, but they're rarely isolated from humans. It's also important to note that the creation of the second genus was controversial and it's still being debated, so sometimes readers may find both taxonomic classifications in published literature. For example, Chlamydiophila pneumoniae also has been referred to as Chlamydia pneumoniae. As shown in Table 24.2, these are species of interest, particularly in human infection: Chlamydia trachomatis, Chlamydiophila pneumoniae, and Pistachiae. So initial differentiation was based on selected characteristics of the growth cycle, susceptibility to sulfa drugs, accumulation of glycogen inclusions, and DNA relatedness. Chlamydia are deficient in energy metabolism, and this is why they are obligate intracellular parasites. In the past, it was believed that they were strictly energy parasites. However, gene sequencing identified the presence of enzymes needed for metabolism of various glucose products, and this allows the bacteria to generate ATP. The bacteria depend on the different sugars from the host cell to survive and metabolize. The growth cycle of chlamydia involves two distinct forms: an elementary body, which is infectious, and a reticulate body, which is non-infectious. The elementary body has spore-like features in that they're resistant to environmental physical stress. The elementary body, the infectious form, has an outer membrane similar to that of many gram-negative bacteria, and the most prominent component of the membrane is the major outer membrane protein. This outer membrane protein is a transmembrane protein, and it contains both species-specific and subspecies-specific epitopes, and these can be defined and identified by monoclonal antibodies. The growth cycle begins when the small elementary bodies infect the host cell. So here we have the elementary bodies, and they're phagocytized by the host cell. They induce this energy-requiring active phagocytosis when they remain within membrane-bound phagosomes. The bacteria prevent interaction of the phagosome with endosomes. In vivo, host cells are primarily non-ciliated, columnar, or transitional epithelial cells that line the conjunctiva, respiratory tract, urogenital tract, and rectum. During the next 8 hours, after cellular penetration, they organize into larger, less dense reticulate bodies, which divert the host cell's synthesizing functions to their metabolic needs and begin to multiply by binary fission. About 24 hours after infection, the dividing organisms begin reorganizing into the infective elementary bodies. And then about 30 hours, multiplication ceases. And by 35 to 40 hours, the disrupted host cell dies, and then this releases the elementary bodies that can infect other host cells, continuing the cycle. Table 24.3 in your textbook summarizes the various human diseases caused by the chlamydia species of clinical importance. We'll go into each of these in a little more detail, but of note, Chlamydia trachomatis causes trachoma, which we'll discuss, along with lymphogranuloma venereum, and these are caused by the different serovires. Chlamydia trachomatis is also the cause of various genital and urinary tract infections. Chlamydophila pneumonia is the causative agent of pneumonia along with other respiratory tract infections. And Chlamydophila pstachyssae is the cause of various infections, including pstachiosis, which is a respiratory tract infection similar to pneumonia, along with endocarditis and abortion. Chlamydia trachomatis has been divided into two biovires, trachoma and lymphogranuloma venereum. In addition, there's been characterization of the major outer membrane proteins, as mentioned previously, that has separated Chlamydia trachomatis into 20 serovariants or serovires. The trachoma biovire includes serovires A through K. Serovires A, B, BA, and C are associated with severe eye infection trachoma, whereas serovires D through K, DA, IA, and JA are associated with inclusion conjunctivitis, which is a milder infection, and these are also associated with urogenital infections. The L serovires, L1, 2, 2A, 2B, and L3, are associated with lymphogranuloma venereum, an invasive urogenital tract disease. So the trachoma biovir, serotypes A, B, and BA, along with C, are the Chlamydia trachomatis serovires that cause chronic eye infection known as trachoma. This is the #1 cause of preventable blindness in the world. These serovires are most frequently found near the equator and are seen in climates with high temperatures and high humidity, so they're not frequently seen in the United States. They produce a chronic eye infection that, if left untreated, generally results in blindness in adults. Prevention and treatment includes antimicrobial treatment, facial cleanliness, environmental improvement, and surgical procedures on the eyelid. The chronic inflammation that can be caused by this infection causes the eyelid to turn inward, and this can result in continual abrasion of the cornea. And the condition results in scarring and ulceration of the cornea that can also result in secondary bacterial infection and ultimately blindness. As mentioned before, the L serovires, L1, 2, 2A, 2B, and 3, are the causative agents of lymphogranuloma venereum, which is a sexually transmitted disease. These serovires are more invasive than others. Patients with lymphogranuloma venereum present with inguinal and anorectal symptoms. Following the incubation period of 1 to 4 weeks, patients develop a small papule or lesion at the site of infection. These serovires are able to survive inside mononuclear cells, and the bacteria then enter the lymph nodes and produce a strong inflammatory response that often result in bubo formation and subsequent rupture of lymph nodes. The serovires have also been linked to paranoid oculoglandular conjunctivitis. Although the prevalence of lymphogranuloma venereum in the United States is not known, it's believed to be uncommon, and it's usually seen in immigrants and travelers returning from countries in which the disease is endemic. It's usually found in tropics and subtropical areas of the world. Other urogenital diseases that can result from Chlamydia trachomatis infection in women include proctitis, which is a common presentation in women as a result of the lymphatic spread of the bacteria from the vagina or cervix. Other infections caused by serovirus D through K include cervicitis, endometriosis, salpingitis, which is inflammation of the fallopian tubes, and then complications can include pelvic inflammatory disease, which can result in sterility, and perihepatitis. Asymptomatic infections can also be common. Men can develop proctitis as a result of lymphatic spread of the organism from the urethra. Other urogenital diseases caused by serovirus D through K also include non-gonococcal urethritis, epididymitis, prostatitis, and then again, asymptomatic infections can occur and are common. Reiter's syndrome is one additional presentation of Chlamydia trachomatis infection that's also known as reactive arthritis, and it's believed to be caused as a result of infection with the organism after urethritis, conjunctivitis, polyarthritis, or mucocutaneous lesions occur. Chlamydia trachomatis is the most common sexually transmitted bacterial pathogen in the United States. Many infections do go undiagnosed as a result of the asymptomatic infections. In the United States, only human papillomavirus is more common than chlamydia infections. Newborns can also be infected with Chlamydia trachomatis while traveling through an infected birth canal. Chlamydial infection in a newborn delivered by cesarean section is rare. An infection from seronegative mothers hasn't been reported. Newborns with chlamydial infection can experience conjunctivitis, nasopharyngeal infections, and pneumonia. Ear infection can also occur as a result of this infection in a newborn, but it's less frequent. In the United States, infants that are born receive prophylactic eye drops. So this is erythromycin drops that are generally used to treat Neisseria gonorrhea, but in addition, they can prevent eye infections by Chlamydia trachomatis. Table 24.4 summarizes the characteristics of inclusion conjunctivitis in a neonate. So the incubation period is usually 4 to 5 days after birth, and signs of infection with Chlamydia trachomatis includes edematous eyelids, in which accumulation of fluid is noticed on the eye area. Discharge is also notable, which appears copious and yellow, so there's large amounts of discharge. If the patient is untreated, weeks to months later, complications can include corneal scarring along with conjunctival scarring that could result in blindness of the infant. In terms of laboratory diagnosis for Chlamydia trachomatis infection, there's numerous methods available that differ in sensitivity, specificity, and positive predictive value. The most appropriate tests or combinations of assays used depend on the following factors: the knowledge of the population at risk, capability and facilities available for testing, the cost of the assays, the ability to batch specimen types, and the experience of the laboratory scientist. The various assays available include culture and then non-culture methods, including direct fluorescence antibodies, enzyme immunoassays, along with non-culture amplified methods such as PCR or molecular methods, and then we have serology. They're then further divided in the assays to determine whether the population at risk is a low risk or high risk, and then divided into prenatal, newborn, or adult populations. So a couple notable things on this table include that culture can be used for both standalone and screening tests, but culture is the only assay approved for test of cure, so determining whether the treatment for infection is successful. In addition, culture, along with amplified PCR methods or molecular methods, are the only assays acceptable for legal applicability, such as in cases of rape or child abuse. Prevalence in the population to be tested is one of the more important criterion in determining which method or combination of methods should be used. For an assay, the positive predictive value increases, assuming optimal technical conditions are in place, when the prevalence of disease in the population is high. The type of specimen selected for laboratory processing depends on the symptoms of the patient and the clinical presentation. It's important to note that regardless of the source, however, the specimen should consist of infected epithelial cells and not exudate, because remember, these are obligate intracellular organisms, so you need the actual cells in which the organisms are living. So here you can see culture is the gold standard for specificity, so testing for those without the disease, but it is a very labor-intensive assay. Direct fluorescent antibody and enzyme immunoassay are appropriate for screening only. So positive results obtained with these methods require some type of verification, such as culture or molecular methods. In terms of specimen collection, dacron, cotton, and calcium alginate swabs are acceptable and can be used, but it should be noted that toxicity has been associated with different lots of each, which is a concern if culture is attempted. In addition, it's important to remember that swabs with plastic or metal shafts should be used opposed to those with wooden shafts, because these wooden shafts can be toxic to the cells. As mentioned before, discharge or exudate is not enough for the sample. Actual scrapings that include the epithelial cells need to be obtained. With urines, a first morning specimen is optimal, and vaginal swabs are also excellent specimen types. Specimens for culture must be placed into a transport medium, such as sucrose phosphate glutamate buffer, and transported to the laboratory at 4 degrees Celsius or below within a 24-hour period. Appropriate specimens include conjunctival swabs or scrapings for patients presenting with inclusion conjunctivitis and trachoma, and various urogenital swabs for patients presenting with the different urogenital presentations. Some specimens may include biopsies, such as fallopian tube biopsy for patients presenting with salpingitis. As mentioned, urine is an acceptable sample, particularly with patients presenting with sexually transmitted infections. And aspirates from buboes or cervical lymph nodes are required for patients presenting with lymphogranuloma venereum. Patients that present with pneumonia should have respiratory specimens sent, such as a throat swab, nasopharyngeal aspirate, or lung tissue, along with washings from the throat, sputum, or bronchial lavage fluid. Patients presenting with Chlamydia cetaceae infection should have respiratory samples submitted as well, such as sputum, bronchial lavage, or pleural fluids, and also lung tissue can be submitted. Direct specimen examination by cytologic methods involves patients diagnosed with trachoma and inclusion conjunctivitis. Cytologic analysis is almost 95% sensitive, but it's a technically difficult test and is influenced by the quality of the specimen and the expertise of the laboratory scientist. Although this method is difficult to use with large numbers of specimens, it does offer rapid results in selected cases, particularly in detecting ocular infection in newborns. Direct fluorescent antibody testing should not routinely be used for genital tract specimens. This method is also labor-intensive and requires experienced lab scientists, and the sensitivity is only 75 to 85%, and there is cross-reactivity with other bacteria that's been reported. Fluorescence observed of the elementary bodies is suggestive of infection, but verification by alternative methods using a different epitope is needed. Here's an example of an inclusion body from an ocular swab of a 7-day-old newborn. So these inclusion bodies are abnormal structures in the cell nucleus or cytoplasm that have a characteristic staining property. In this particular case, the 7-day-old was discharged, but then readmitted with fever, weight loss, lack of eating, and fussiness. And at 3 days after delivery, Neisseria gonorrhea was isolated from ocular discharge, even though the patient was already given silver nitrate eye drops. The eye culture confirmed the presence of Chlamydia trachomatis. Direct specimen examination does offer an additional important advantage. It allows for immediate quality control of the specimen, revealing whether columnar epithelial cells are present. So here's an example of cytologic examination of endocervical specimens demonstrating inclusion bodies consistent with Chlamydia trachomatis. Both these images or slides are stained with Papin-Cola stain, and here you have some of the inclusion bodies in the epithelial cells, and on the right as well. Until the development of nucleic acid amplification testing, chlamydial cell culture was the gold standard for detecting Chlamydia trachomatis infection. The cell lines used for detection of chlamydia include McCoy, Gila, and buffalo green monkey kidney cells. The cell lines are typically grown on cover slips containing cell culture medium with cyclohexamide to suppress host cell protein synthesis. They can also be grown on the surface of multi-wall cell culture dishes containing the media. The sample is then added and centrifuged onto the cell monolayer and then incubated for 48 to 72 hours. Fluorescent labeled monoclonal antibodies can be used to detect the chlamydial inclusions. There are a number of commercially available fluorescent antibodies. Some laboratories use species-specific monoclonal antibodies to bind to the major outer membrane complex, whereas others prefer family-specific antibody, which bind to the lipopolysaccharide component of the organism. As mentioned, although cell culture was the gold standard, the usefulness of this method has been limited because of technical complexity and time and specimen handling requirements, along with expense and the label nature of the chlamydia organism itself. Iodine and Giemsa stain have also been used to observe the inclusion bodies, and here's an example of an iodine-stained inclusion body of Chlamydia trachomatis on an infected McCoy cell. So here you have the inclusion body, but it's important to note that these methods, both iodine and Giemsa, are less sensitive and specific, so they're no longer recommended. So mainly the methods use fluorescent labeled monoclonal antibodies. Enzyme immunoassays can also be used in detecting Chlamydia trachomatis, and they use monoclonal or polyclonal antibody directed against the chlamydial lipopolysaccharide. There's several commercial kits available, and they all have similar advantages. They include the ability to screen large numbers of specimens, obtain objective results, and have test results available within 3 to 5 hours using various specimen types. With the enzyme immunoassays, none of them have the sensitivity of culture. In addition, although they can accept various specimen types, they're not appropriate for urine or vaginal swab specimens. Because of high sensitivity and specificity, nucleic acid hybridization and amplification assays, known as NATs, are the preferred method. Nucleic acid amplification tests offer several advantages, including FDA approval to detect Chlamydia trachomatis in endocervical swabs from women, urethral swabs from men, and urine specimens from men and women. These assays also have an advantage of detecting 2 sexually transmitted diseases in one sample, so several current methodologies will detect both gonorrhea and Chlamydia trachomatis infection. In general, antibody detection using serologic assays have little value in detection of Chlamydia trachomatis infection. Serologic testing of uncomplicated genital infections and screening of asymptomatic individuals is not recommended. Currently, the interpretation and significance of serologic assays are being evaluated, and serologic testing is growing as a complementary diagnostic tool in certain situations, such as with microimmunofluorescence when a specific IgM response to a different serovir of Chlamydia trachomatis is observed. New infections can be diagnosed in patients who have previous infections with other serovirs. Another situation is in ascending infections by Chlamydia trachomatis involving the fallopian tubes and other organs of the upper female genital tract. Patients at risk for chronic infections would be missed with standard screening methods using a cervical swab, so serologic testing of women with subfertility has been proposed as a screening test. One additional certain situation includes complement fixation, which detects family reactive antibody, including elevated levels of antibody in systemic infections, such as in lymphogranuloma venereum. Diagnosis of LGV is supported by complement fixation titers of 1 to 64 or more. Since there is a large variety of testing choices, it's important for each lab to clearly report and define their results. Some important points in development of an approach to ordering and reporting results for Chlamydia trachomatis and related organisms include agreeing in advance with the obstetrics, gynecology, and emergency departments on which organisms are associated with clinical syndrome and then testing accordingly, reporting which tests were and were not performed for each patient profile, and providing the significance and interpretation of positive results. The next Chlamydiaceae genus we'll talk about is Chlamydophila. So we'll talk about Chlamydophila pneumonia. So this was formerly known as Chlamydia species strain Toir, and it was named this because it was originally identified in 1965 from a conjunctival culture of a child enrolled in a Taiwan trachoma vaccine study. It is now known as an important respiratory pathogen, and only one serovir has been found. About 90% of Chlamydophila pneumonia infections are either mild or asymptomatic, but it has been known to cause several respiratory presentations such as sinusitis, pharyngitis, acute respiratory disease, bronchitis, and pneumonia. It's also been isolated from patients with otitis media with effusion, pneumonia with pleural effusion, and aseptic pharyngitis. Chlamydophila pneumonia has also been implicated as a possible factor in asthma and cardiovascular disease. The organism has been isolated from arteriosclerotic tissue, but its possible role and pathogenicity still is under investigation. Although many infections are asymptomatic, infection with Chlamydophila pneumonia is thought to be fairly common in the United States. The clinical picture in an average college-age student, although this can be varied, is a biphasic clinical course. It results in prolonged sore throat that lasts from 5 to 7 days and hoarseness, followed by flu-like lower respiratory tract symptoms within 8 to 15 days. Because of its similarity to bacterial pharyngitis, the results of a streptococcal antigen test is often thought to produce false negative results. The second phase of the biphasic illness often results in pneumonia and bronchitis, but this is rarely accompanied by sinusitis. Fever in infection is uncommon, and radiographs show isolated pneumonitis. As you can see from the epidemiologic features, there's almost no antibody detectable before 5 years of age, but then as age increases, more than 50% of adults have antibodies, with the attack rate being highest between the ages of 6 and 25 years old, so young adults, more on college-age students. Specimens collected for detection of chlamydophila pneumonia include sputum, bronchial lavage, nasopharyngeal aspirates, throat washings, and throat swabs. It may be cultured on selected cell lines and visualized with fluorescent conjugated monoclonal antibodies. Human cell lines, including HEP2, are the most sensitive for this species. Monoclonal antibodies specific for chlamydophila pneumonia are used to identify inclusions in cell culture. Since there has been difficulty and lack of standardization for isolation of chlamydophila pneumonia, serologic tests have been useful for diagnosis. Complement fixation tests have been used more often, but now they're rarely used, and the present method of choice is the microimmunofluorescence assays, which are more sensitive and specific. Currently, or recently, there have been some ELISA methods in process, but none of them are FDA approved yet. So once these methodologies are available, they'll have some major advantages, such as being less time consuming and not relying on user fluorescence observations or experience of the lab scientists. But again, ELISA, although a promising methodology, is not readily available for detection of chlamydophila pneumoniae. Chlamydophila cetaceae is the last species we'll talk about in the family Chlamydiaceae. So this organism can cause infections in avian and mammalian species. In avian species, it causes an infection known as parrot fever, also known as ornithosis. The mammalian strains can cause feline conjunctivitis, rhinitis, and respiratory infections among cats, and it can cause guinea pig conjunctivitis. Inhalation of the bacteria following contact with poultry is the greatest risk of infections for humans, and person-to-person spread is not common and unlikely. Human infection can be asymptomatic or mild, but it can also present as severe pneumonia. Symptoms include fever, chills, muscle aches, severe headache, and occasional gastrointestinal symptoms. Diagnosis of human psittacosis is usually based on history of exposure to birds, and then observing a fourfold rise in the level of antibody to the chlamydial group lipopolysaccharide antigen. In the United States, there's fewer than 50 cases of this infection reported annually. Misdiagnosis is a problem, and this is why it's important for physicians to know the tests that are most appropriate for differentiating these microorganisms. In addition, it's also important for the physicians and clinical staff to have relevant clinical history for the patients. Isolation of Chlamydophila cetaceae in culture, although diagnostic, is difficult and also dangerous and not routinely recommended. Almost all diagnosis of this infection is based on serologic evaluation. So a single antibody titer greater than 1 to 32 is suggestive of acute illness in symptomatic patients during an outbreak. The rise of levels of antibodies is usually not demonstrated until the acute illness is over. However, it is often weak or absent if appropriate antimicrobial therapy is given. Again, a good patient history is very important in evaluating the patient diagnosis, especially knowing exposure to birds, the incubation time, and disease process for this particular organism. There are no commercially available nucleic acid amplification tests available. And there are some PCR-based assays that have been published, but lack of a gold standard for comparison has made this evaluation difficult as well. So next we'll move to the genre Rickettsia and similar organisms such as Orentschia. These all belong to the family Rickettsiaceae. Typical characteristics of the members of this family include that they are arthropod-borne. Again, they are obligate intracellular pathogens. These organisms only grow in the cytoplasm of hosts, and the primary hosts have minimal to no disease from their rickettsial infection. Since the primary hosts do not have any disease, this allows the Rickettsia to persist in nature. Rickettsia are passed through new generations of arthropods by transovarial transmission. What this means is the arthropods are able to pass the Rickettsia organism down to their offspring. Because of this, the arthropods are not only vectors for Rickettsia, but also reservoirs. The arthropods can also directly inoculate new hosts with Rickettsia during feeding. An exception to this pattern occurs only with Rickettsia proazacii. In this case, the arthropod vector, the body louse, can die from rickettsial infection, and humans act as the natural reservoir. Rickettsia are short, non-motile, gram-negative rods, about 0.8 to 2 micrometers by 0.3 to 0.5 micrometers in size. The members of this genus Rickettsia have not been grown in cell-free media, but have been grown in the yolk sacs of embryonated eggs and several cell lines. Rickettsia species are divided into 3 groups according to the types of clinical infections they produce. The typhus group contains only 2 species, Rickettsia proazacii and Rickettsia typhi. The spotted fever group includes a number of species recognized as human pathogens, such as Rickettsia rickettsii, Rickettsia connorii, and Rickettsia africae. The transitional group contains Rickettsia acari, australis, and felis. It is important to note, because of the infective aerosol dose being low, Rickettsia rickettsii, proazacii, typhi, and connorii are considered potential bioterrorism agents. The Rocky Mountain spotted fever group is the most severe of the rickettsial infections. Rocky Mountain spotted fever is caused by Rickettsia rickettsii and was first described in the western United States. Rocky Mountain spotted fever is a zoonosis, and humans typically acquire the infection by tick bites, so they are the accidental hosts. Usually Rickettsia is transmitted by tick vectors Dermocenter variabilis or Dermocenter andersoni. Other species of ticks can be vectors as well, but these are ones that are more documented. Clinically, after an incubation period of about 7 days, a patient experiences flu-like symptoms for approximately 1 week. They include fever, headache, myalgia, nausea, vomiting, and rash. The rash may be hard to distinguish, and it begins as erythematous patches on the ankles and wrists during the first week of symptoms. It can then extend to the palms of the hands and soles of the feet, but normally will not affect the face. The maculopapular patches eventually consolidate into larger areas. Once disseminated, the organisms cause vasculitis in the blood vessels of the lungs, brain, and heart, leading to pneumonitis, central nervous system manifestations, and myocarditis. The patient experiences symptoms secondary to vasculitis, including decreased blood volume, hypotension, and disseminated intravascular coagulation. The mortality rate for untreated or incorrectly treated patients can be as high as 20%, although correct antimicrobial therapy with tetracycline or chloramphenicol lowers the rate to 3 to 6%. Bhutanese fever is another presentation in the spotted fever group that's caused by Rickettsia cornorii. It's also known as Mediterranean spotted fever, and it occurs primarily in France, Spain, and Italy. Similar to the organism that causes Rocky Mountain spotted fever, Rickettsia cornorii is also tick-borne, and its reservoirs include ticks and dogs. Rickettsia cornorii is also the causative agent of other disease presentations in other areas of the world, including Kenya tick typhus, South African tick fever, and Indian tick typhus rather. Bhutanese fever is also clinically similar to Rocky Mountain spotted fever. The rash involves the palms of the hands and soles of the feet, just as Rocky Mountain spotted fever. The rash of Bhutanese fever, however, also will involve the face, and this helps in differentiating them as well, the clinical presentation. Bhutanese fever is characterized by the presence of taches noirs, also described as black spots at the primary site of infection. These are lesions caused by the introduction of Rickettsia cornorii into the skin of a non-immune person. As the organism spreads to blood vessels in the dermis, damage occurs to the endothelium. Edema secondary to increased vascular permeability reduces blood flow to the area and results in local necrosis. The next group of Rickettsia is the typhus group. So this includes Rickettsia typhi, which is the causative agent of endemic typhus, also known as murine typhus, and Rickettsia prowazekii, the causative agent of epidemic louse-borne typhus, also known as Brill-Zinsser disease. Rickettsia prowazekii is primarily found in Africa and Central and South America. An important characteristic to note with the typhus group Rickettsia are that unlike the other Rickettsia species, these ones replicate in the cytoplasm of the host cell and cause lysis and organism release, whereas other Rickettsia pass directly through an uninjured cell. Vectors for Rickettsia typhi are the oriental rat flea, Xenopsylla schiopsis, and the cat flea, Tenocephalidus felis. Rickettsia can survive in nature by transovarial transmission, so when a flea feeds on an infected host, the Rickettsia enter the flea's midgut and they replicate in the epithelial cells. They're eventually released into the gut lumen, and then humans become infected when fleas defecate on the surface of the skin while feeding. Rickettsia typhi can also be transmitted to humans directly from the flea bite itself. Presentation with Rickettsia typhi infection includes fever, headache, and rash, so it can present similarly to Rocky Mountain spotted fever, with the exception that it does not always produce a rash. When the rash is present, however, it usually will occur on the trunks and extremities, and rash on the palms of the hands occurs very rarely. Louse-borne typhus, also known as epidemic typhus, is caused by Rickettsia prowazekii. The vectors include the human louse, Pediculus humanus, the squirrel flea, Orchopeus howardii, and the squirrel louse, Neohematopenis schiriperii. The reservoirs are primarily humans and flying squirrels located in the eastern United States. The louse often dies as a result of rickettsiemia, unlike the other vectors of Rickettsia that can survive with infection by the organism. Louse-borne typhus is still commonly found in areas of Africa and Central and South America where unsanitary conditions promote the presence of body lice. The lice are infected with Rickettsia prozacii when feeding on infected humans. The organisms invade the cells lining the gut of the louse, and then they actively divide and eventually lyse the host cells, spilling the organisms into the gut lumen. When the louse feeds on another human, it defecates, and the infected feces are scratched into the skin, similar to the way murine typhus is transmitted. The disease progression is similar to that of Rocky Mountain spotted fever, including involvement of the palms of the hands and soles of the feet with the rash. Unlike the cases with Rocky Mountain spotted fever, the face may also be affected by the rash. Brill-Zinsser disease, also called Rickettsia typhus, is seen in patients who previously had louse-borne typhus. Rickettsia prozacii lies dormant in the lymph tissue of the human host until infection is reactivated. Brill-Zinsser disease is a milder disease compared with louse-borne typhus, and death is rare. Patients with this latent infection are an important reservoir for the organism. The last group of Rickettsia are the transitional group. So these cause disease presentations such as rickettsial pox. Rickettsial pox is caused by Rickettsia arcari, and the reservoir is the common house mouse, with the vector being the mouse mite. Rickettsial pox occurs in Korea and Ukraine, and then in eastern parts of the United States, including in New York City, Boston, and Philadelphia. The infection typically occurs in crowded urban areas where rodents and mites exist. Rickettsial pox has similar presentation to Rocky Mountain spotted fever, but is milder. The rickettsial organism enters the human host following a mite bite. The incubation period is about 10 days, and then a papule forms at the site of inoculation. The papule will progress to a pustule and then to an indurated eschar, so a larger lesion. The patient becomes febrile as the rickettsia are disseminated through the body through the bloodstream. The patient will experience headache, nausea, and chills. Unlike Rocky Mountain spotted fever, the rash of rickettsial pox appears on the face, trunk, and extremities and does not involve the palms of the hands or soles of the feet. Rickettsial pox symptoms resolve without any medical attention. Organisms was formerly classified as Rickettsia, so we'll discuss this genre briefly here. Scrub typhus is a disease that occurs in India, Pakistan, Myanmar, Eastern Russia, Asia, and Australia. The causative agent is Organisms, formerly Rickettsia susugamoshi. The vector is the chigger, and the main reservoir is the rat. The bacteria are transmitted transovarially in triggers. The transmission of Rickettsia to the human host is followed by an incubation period of approximately 2 weeks. A tache noir, the black spot similar to that of Boutonniere fever, forms at the site of inoculation. The normal symptoms of Rickettsia infection include fever, headache, and rash. The rash starts on the trunk and spreads to the extremities. Unlike the case with Rocky Mountain spotted fever, the rash does not involve the palms of the hands and soles of the feet, and the face is also not involved. As mentioned before, because of their infectious nature, isolation of Rickettsia is not recommended and should be attempted only by biosafety level 3 laboratories. If culture is attempted, blood should be collected as early in the disease course as possible. The immunohistochemical and molecular detection of Rickettsia is an established method for diagnosis of these infections. However, these assay methods are available only in a few laboratories in the United States. Monoclonal antibodies directed against spotted fever or typhus group have been used, but no antibody is commercially available. Nucleic acid amplification tests have been described, but they too are not readily available. Typically, serologic assays are the only laboratory test performed for the diagnosis of rickettsial diseases. These methods can confirm a diagnosis only in convalescent specimens, so they offer little help in diagnosing acute infections that could guide antimicrobial therapy. IFA, the immunofluorescent antibody test, is considered the gold standard method for antibody detection. The next family we'll discuss is Anaplasmataceae, and the group members of this family consist of Ehrlichia, Anaplasma, and Rickettsia. Ehrlichia are obligate intracellular arthropod-borne cocobacilli. They differ from other members of the Rickettsia in that they multiply in the phagosomes of host leukocytes and other cells derived from the bone marrow, not in the cytoplasm of endothelial cells. There are two forms of Ehrlichia similar to that of Chlamydia. There's the denser infective elementary body and the reticulate body that replicates in the phagosome and prevents phagolysosome formation. As was mentioned, cell multiplication occurs in the phagosome of the host leukocytes. As the cell divides within the phagosome, mulberry-like bodies form called morulae. These are round to oval clusters of bacteria that measure 1 to 3 micrometers in diameter. As the host cell ruptures, the morulae break into many individual elementary bodies, which continue the infective cycle of the organism. This figure depicts an infected white blood cell with an anaplasma morulae. Circled in red is the phagosome in which the organism is multiplying. Ehrlichia is the first genre we'll discuss in the family Anaplasmataceae. Ehrlichia schiffensis causes human monocytic ehrlichiosis. This occurs in the United States, Europe, Africa, and South and Central America. In the United States, most cases are found in southeastern and south central states, as well as the mid-Atlantic states, with Oklahoma, Missouri, and Arkansas accounting for a large percentage of cases. Ehrlichia ewingii produces a disease that's indistinguishable from the ehrlichiosis caused by Ehrlichia schiffensis, and there's no currently available serologic test that can distinguish these two agents. Natural hosts of the organism include dog and deer, as well as humans, with the lone star tick being the primary vector. Many patients with human monocytic ehrlichiosis are asymptomatic. The organism has an incubation period of 5 to 10 days. Patients that have symptoms experience high temperatures, headache, malaise, and myalgia. Nausea, vomiting, diarrhea, cough, joint pain, and confusion are rarely present. As many as 67% of pediatric infected patients have a rash with Ehrlichia schiffensis. However, adults rarely experience a rash. Patients with infection can also present with leukopenia and neutropenia, thrombocytopenia, and elevated liver enzymes. Severe complications of infection include toxic shock-like syndrome, central nervous system involvement, and acute respiratory distress syndrome. Direct staining using Giemsa or Wright stain of peripheral blood smears or Buffy coats for morulae can be used for diagnosing Ehrlichia schiffensis, such as the figure we saw previously. However, this method is not very sensitive. Antigen detection in tissues such as bone marrow, liver, and spleen have been described, but sensitivity for this is low, and cross-reaction with other species has been documented. Nucleic acid amplification tests are frequently used for detection of Ehrlichia. Recently, real-time PCR and multiplex PCR have been used as well. The bacteria have also been isolated from peripheral blood in cell culture. Most cases of human monocytic ehrlichiosis are diagnosed retrospectively by serologic testing, with immunofluorescent assay testing being the most widely used method. Anaplasma phagocytophilium, which was formerly known as Ehrlichia phagocytophilium, causes a disease called human granulocytic anaplasmosis. The incubation period for human granulocytic anaplasmosis is 5 to 11 days, and the symptoms closely resemble those of human monocytic ehrlichiosis. This organism is endemic to the upper Midwest and Northeast United States, with the reservoirs being deers, rodents, horse, cattle, and humans. The tick vectors include Ixodes scapularis and Ixodes pacificus. Similar to human monocytic ehrlichiosis, staining of peripheral blood and buffy coats can be used to diagnose human granulocytic anaplasmosis. And this method has a higher sensitivity than that when detecting ehrlichiosis. Stained buffy coat preparations are preferred because many patients have less than 1% infected granulocytes, and they also have leukopenia. Diagnosis can also be made by using direct antigen detection, nucleic acid amplification tests, and isolation in cell cultures. Immunofluorescent antibody serologic kits are also available for detection of antibodies to anaplasma. Coxiella burnettii is an important organism to be aware of, and it's the only species in this genus. It's important because it is the causative agent of Q fever, which is highly contagious and is also considered a potential bioterrorism agent, which will be discussed again in Chapter 30. Coxiella differs from members of Rickettsia and Anaplasmataceae because it can grow in cell-free media, and it can be considered a facultative intracellular parasite. Coxiella does develop within the phagolysosome of infected cells. It does produce spores that allows it to survive harsh environmental conditions, but it's generally not transmitted by arthropods, although it is known to infect more than 12 genera of ticks and other arthropods. The bacteria can also infect fish, birds, rodents, livestock, and other mammals. Coxiella burnettii is the causative agent of Q fever, as mentioned, and this disease is found worldwide and is highly contagious. Most infections are spread by inhalation of dried birthing fluids of several animals, so exposure in vet or animal handling settings are the frequent areas in which humans become infected. The ingestion of unpasteurized milk is also a recognized risk factor for Coxiella infection. Acute Q fever generally has an abrupt onset of undifferentiated febrile disease. Symptoms include high fever, headaches, myalgia, arthralgia, cough, and sometimes a rash is present. Patients present with elevated liver enzymes, increased erythrocytic sedimentation rate, and thrombocytopenia. Because of the rapid dissemination of the bacteria, a number of tissues can be infected, resulting in chronic disease, with the cardiovascular system being most susceptible. Laboratory diagnosis of Q fever can be made by direct immunofluorescent assay of infected tissue. It's important to note, with the exception of heart tissue, in the cases of endocarditis, other infected tissues typically contain low numbers of bacteria. Nucleic acid amplification testing, such as PCR, have also been used in diagnosing infections. Whole blood and buffy coats are often successful in detecting the organism, but since the organism is highly contagious, isolation and cell culture should be attempted only in a biosafety level 3 facilities. There are several serologic assays available for detecting antibodies in both acute and chronic cases. IFA testing is the method of choice, but there are also alternative methods using enzyme immunoassay kits that are commercially available and FDA approved. So in summary, several important things to remember covered in this chapter include that chlamydia and Rickettsia are obligate intracellular organisms. Within Chlamydia, the important genera are Chlamydia and Chlamydophila, with Chlamydia trachomatis being the most common sexually transmitted disease, in which certain serovirs cause trachoma and blindness, while others cause lymphogranuloma venereum. Chlamydophila pneumoniae is a common respiratory pathogen that is responsible for cases of community-acquired pneumonia, and Chlamydophila cetaceae is associated with birds and causes lower respiratory tract infections in humans. So both of these Chlamydophila species are associated with primarily respiratory presentations, whereas Chlamydia trachomatis is with sexually transmitted diseases and urogenital infections. Rickettsia species are mostly arthropod transmitted organisms, and they're responsible for several diseases grouped into the Rocky Mountain spotted fever group, rickettsial pox, and the typhus group. Ehrlichia and Anaplasma are intracellular parasites of white blood cells, with Ehrlichia causing human monocytic ehrlichiosis, affecting mononuclear cells, and Anaplasma causing human granulocytic anaplasmosis, affecting granulocytes. And finally, Coxiella burnettii is the causative agent of Q fever and is an important agent to remember because it's a potential bioterroristic agent.